Hi everyone. I hope you come find the second part of that. I made a mistake and clicked on something I shouldn't have, and it doubled my video, and I was hearing myself with feedback. I apologize. So I really hope you guys find me again. Anyway, let me give you guys a couple of minutes to find me. I apologize. Hi Nahama, I'm glad you found me. I'm afraid I lost everybody else somehow because I was live and then suddenly I clicked on the wrong thing and everything doubled. So I'm waiting to see if people can re-find me. I apologize for the confusion. Clearly, even though I practiced doing a live this morning, there's a learning curve. And I think that's okay, you know. We should all know that nobody's first attempt at something is going to be perfect, right? So I'll get better at it, just like everybody else gets better at everything. And that's one of the things I do want to talk about today. But waiting to see if you guys got back in here. Give me another little hi so I know. And I was telling you my story about my sister and how growing up with her really influenced my interest in speech-language pathology. And then during my life's course, I worked with all different populations from birth to end-of-life care. And I really loved it all, but I found that I really resonated with aphasia. And the way I found my big interest in aphasia was after I had gotten married, I worked at a day health center for adults. So they went there during the day, but went home at night. And the model made it so that I didn't have restrictions on my time because everybody was being paid, everyone paid the same rate, regardless of what therapies they got, and all therapies were available to them. So I got to work with people from the beginning of their brain injury or stroke until they didn't need me anymore. And I could see them every day if I wanted. That's not a model you find often. So in that, I saw how much when people have the right attention and when they have the right amount of therapy that they need, they can really improve. So I'm hoping, then I started hoping that I could do more in that realm. So I started exploring the research on aphasia therapy, and I realized that a lot of what we had been taught, at least at the time I was going to graduate school for my master's degree, was actually not what was as useful as they originally thought. So we were told to do drills, we were taught to, pick something for the person to work on, and then they do it as homework. And we were taught, to see people for a half hour, 45 minutes, maybe an hour, 2 or 3 times a week. And that turned out not to be the best thing. So everything that I was reading 15 years after, well, maybe 10, it was more 10 years after I had gotten my master's degree, started making me rethink all my therapy practices. And I started using some of the newer ideas that I learned with my patients, and they were thriving. I had one patient who came to me at 19 years old after a horrific head injury. And he had been drag racing with his friends on a major New York highway. And he was going at 120 miles per hour, and his car hit straight into a tree, right down the midline of his car. And it was going so fast that the car actually got cut apart by the tree. He was not wearing his seatbelt, and he flew through the windshield and landed on his head. So, 19 years old, he comes to me after having been in a coma for months. He had been at a rehab hospital, the acute care hospital for a long time after the coma, and then a rehab facility. And then he came to me at the adult day health center I worked at. at 19 years old, he came to me with slurred speech, a lot of cognitive problems, using a walker, and some aphasia as well. So here I'm talking about someone who didn't have strictly a case of aphasia, because aphasia itself doesn't have all of those components. Aphasia is a disorder of language only. But because of the diffuse, widespread nature of his head injury, he had many different disorders, head to toe. And after, I actually remember when his mother came for a tour of the facility, she was crying. And as a mother of special needs children, I understand, because I've cried seeing the places my kids were going to. But I told her, I'm going to work with him really hard. He's not going to be sitting by himself, like he might be at home, and I'm going to work him, where I'm going to push him, I'm going to challenge him. He's going to work hard. And, I was doing that with other people as well. And they told her, we have fun here too. And we do a lot of good therapy and people get better. And she was looking around because we also had older people. Anybody over the age of 17 could go there. And he was 19. So he was obviously one of the youngest people there. But I cannot even tell you the growth that I saw in him, right? So he went from all the disorders I told you about, plus he had never been much of a scholar, he told me in high school, that 2 years later he left, and of his own volition, he went to community college. He got a 2-year associate's degree in, of all things, medical billing, which has intense vocabulary, terminology, reading, language skills. He passed. He's been like a professional 9-to-5 valued member of a hospital facility for all the years since. And I am so proud when I think of that. And he's still in touch with me. We had such a bond. So all this to say that the reason I've been so nervous leading up to today is that I really want to help people. And I continued my education past the master's degree. I went back for a PhD from NYU, and I received that. I have a PhD. I studied basically the neuroscience of language, and my dissertation was on using people with aphasia and trying to stimulate further brain health using non-invasive brain stimulation. So that was my dissertation. I've written other papers as well, and my broad interest is language production and recovery. So that's me, okay? And then to make a quick disclaimer, I am a New York State licensed and ASHA certified speech language pathologist. And we have certain rules and regulations regarding our scope of practice. So anything that I tell you today is of a general nature based on my experiences and my opinions, and should not be used as medical or speech pathology advice, strictly speaking. It is very important that you see your own doctors, neurologists, and speech pathologists so that you are properly diagnosed and treated for exactly what you need, okay? But I can give you good general advice, encouragement, motivation, stories, and all the tips that I can possibly think of. Okay, so I just want to take a quick second to see in the comments if I've missed anything. And, oh good, okay. Tom, hi, I'm glad you made it back over here to my second live stream. Yes, technology can be quite a frustration, Lahama. I have some friendly support from friends and family as well here, I see. Thank you guys. Thank you for the happy birthday wishes. Yeah, that was a horrible story. I'm so glad it has the ending that it has. And sometimes he says to me, if he didn't have that car accident, he doesn't know what path he would be on, because he was that kid drag racing at 120 miles per hour on a New York highway. So he's pleased with his recovery. Thanks again for all the birthday wishes. Okay, so having told you about myself, many of you know me personally, so that's great. But I see here that we have people who are professional speech pathologists. We have people whose family members have had strokes and have aphasia. I see people who have aphasia or have recovered from aphasia themselves. And I see people with all different experience levels in this. So today I want to acknowledge that I may be saying some things that you already know, but I would like to, equalize the playing field so we're all in this together. Another thing I wanted to say is some people might consider me an expert in this area, and academically, I guess I would agree. But I want to acknowledge that there are so many types of expertise in aphasia. So you're an expert if you lived with aphasia and recovered. You're an expert if you're living with aphasia and are working through it on your journey. You're an expert on aphasia if you care for someone who has aphasia. And I don't discount any of those viewpoints. So when we talk, I would love in the feedback and comments for you guys to chime in on whether you agree, disagree, what's worked for you, etc. Okay? And today, the way that I've chosen to go to make it a little simpler for myself, since I've never done a Facebook Live before, you'll be typing comments to me. In the future, I may try Zoom, where other people can talk and we can speak directly to each other. But I wasn't sure I could manage that today, and look what happened. So we already know, that might not have worked. Okay, so basically for today, I wanted to share with you what, when I was making out the list, turned out to be 3 H's, okay? My 3 general topics are H's. Hope, health, and healing together. I cheated because, the 4-H club was already out there, so this is 3 H's. My 3rd H is help. So hope, health and healing, and help. I think those are 3 things that cover the gamut of what people living with aphasia in any form need. So things I'm thinking about are things like hope. I know a lot of you hear things when you first have a stroke or when your family member first has a stroke that are doomsday scenarios. And I can't imagine getting news like that. But a lot of it, like I told you about the research that I found 10 years after my master's degree, a lot of the information is old and isn't true. And there's scientific evidence for the fact that people can do way more than what doctors might have told you, okay? So have any of you heard this? Let me know in the comments. Tell me yes if you've heard this. Whatever your like or your person that you care about with aphasia is like at 6 months or maybe a year after the stroke, that's all they'll ever get back. Have you heard that? Give me some yeses if you've heard that before. I'm assuming people have heard that because I've heard neurologists say that to people, and that is not true. That is the period we generally consider spontaneous recovery, 6 months to a year. That's a time when, because of the way the brain works, your brain is healing and you are improving on your own. Your brain would be doing that on its own. Okay? But with therapy and other good experiences, people can continue to improve their language forever. Forever. I have had people come to me 15, 20 years after stroke, had not had therapy in 15 or 20 years, and came to me either because one was a clinical trial I was doing, an experiment for my doctoral program. Some were just people I met through living my life who said, oh, you do that? My so-and-so has that problem. And I've started working with them, and they start to improve, okay? So that 6 month to 1 year mark is not true, okay? Yeah, and Nahama, you're right. Nahama is a speech pathologist. She said she's pretty sure that's what she heard in graduate school in the 90s. Me too. And it's just not true. Let me look at these other comments. There's some really good things here. Okay. So, similar thing happened to my cousins. Skidoo accident and crazy motorcycle accident, but no brain injuries. Wow, that really is miraculous. Oh, Diane. Thank you so much for being here. Diane is a caregiver of a wonderful person recovering from aphasia. Michael, she says, is doing his speech therapy by use of Zoom through SCSU, which I think is Southern Connecticut State University. Yes, I'm using Zoom for a couple of clients right now. It's a new format for me. So again, I have that learning curve, as you saw with my Facebook Live today, but we're working on it. Yes, Tom, you heard it. Maureen, you heard it. That's discouraging, right? Hearing 6 months or 1 year and you're done. How urgent must it feel then that you better hurry up and scramble and get it going? That's not the way the brain heals. If you have a brain injury, your brain needs to rest a little bit. I usually don't take someone on intensively until at least a month has passed. Sometimes I lose clients because of it, because they want to go right away. And if you're in a hospital, they start you right away. I don't know. The research I read makes me think the brain needs some time to heal. People will tell me they're so tired. Take a nap. But I'm not a nap person. I don't sleep during the day. Take a nap. Meditate. Close your eyes. Listen to some music. Don't watch so much TV. Don't put so much pressure on yourself. Tell people you can't meet them out for a little while. You need this time to let your brain heal. Okay. Oh, Carrie, I didn't know you heard that about someone with a stroke our own age. It's just not true for any age, right? Tom, I love that. Yes, people continue to recover forever. You do need, and you talk about this all the time, I know this, you need those activity-dependent neuroplasticity learning and training tools to do that and to do it well. But yes, you can do it forever. Absolutely. No doubt. Diane, when Michael was diagnosed after the stroke, we were told he would be a vegetable if he even lived. I've met Michael. That's not true. This guy is walking and talking and thinking and joking, and look at that. Can't always listen to the experts. Sometimes the knowledge of the experts is more general than the specific condition that your person or you have, right? Same with speech pathologists. There's a lot of great speech pathologists who I wouldn't send my aphasia patients to, because their specialty is something else, like child speech or disfluencies, like stuttering, right? So you don't want to get speech therapy from someone whose specialty is outside of your needs, right? So let's see. Michael, though, a vegetable. No. I love it. He's really shown them. I wonder, has he gone back and have these doctors seen his success? Because they need to modify what they say to people, these doctors. Carrie, your friend was told this in regards to all aspects of her recovery. Well, if she hasn't heard the latest news, please tell her that these things are not true. And in all aspects of neurorehabilitation, because all of our systems are very similar neurologically. And motor recovery of limbs and balance and some visual problems and things like that that can also come from a stroke definitely can improve, again, with activity-dependent neuroplasticity, which is code for just saying really good targeted experiences to help that person learn and to let their brain reorganize in a useful way, right? Because some of the things people do, and we were taught, like Nahama said back in the 90s, right, was things like, oh, well, have them use pictures. Just show pictures to people. Well, I can't even tell you how many times I gave people picture systems or things that are kind of like iPads. They're older technology, but they basically had symbols that people could use to construct messages, things like that. Dynavox was one brand. I remember OT, usually occupational therapists, would write out all the forms to get it paid for, and then I would program it. We would go through it. We'd try to personalize it with scenarios. I remember personalizing a Dynavox so that it would say, hi, I would like to order a large cheese pizza. And then it had the person's name and address. And so that that thing was in the closet. People want to speak. Okay? We can use other strategies to enhance communication, but I kind of have a strong feeling that people want to speak and go back as close to normal as they can be. So I like to use other things like writing and reading and pictures and things like that to support speech, but my sessions always involve the person speaking. Even if I have to go to all the cueing in the world, which to me the maximum amount of cues and help and hints is repetition. I say the word, they look at me and use their motor neurons to say it with me. But I want them speaking in every session. So not everyone agrees with me on that, actually. So there's a lot of speech therapists who just care about the communication and just making sure the message is understood. And I totally am there, and that's my primary goal. But I figure once I figure out and we get the message out in any way necessary, let's say it. So I just like to add that piece. That's my personal approach. Let's see. Oh my gosh, Tom, that's profound. He says, we learn forever. You can't not learn. Wow. You can't not learn. It's true. Now I'm thinking about this. This is from my first time thinking about this. But it's true. Like every day we're learning new concepts, new technology, names for new technology, names for concepts and ideas we never heard of before. Novel coronavirus words. We're always learning. That's true. Further, you say, you can refuse to learn, but that takes a lot of energy to not learn. Yeah. because our brains were born to make patterns and recognize them, and our brains want to learn. They want to make sense of the world. Very good points, Tom. I don't know what doctors are thinking when they make doomsday predictions like that regarding how long a person will live or how much their brain will heal. It's the God complex at its worst. Yeah, it is partially that. And it's also partially their training. They're taught, I think, most doctors to be very authoritative in how they present things to people. They are the authority, and I also, for benefit of the doubt purposes, I also think it's based on their training as well. Just like we were saying about ours was outdated at some point. Maybe their knowledge has not been updated. So, but there's many reasons and many personalities, and every physician is different. Listen to your body, right? One of the best forms of advice. Right. I'm tired. Take a nap. I need to go to bed early. Go to bed early. It hurts my head when I'm watching TV or I'm on my phone. Don't look at screens. Take some time for that. Yes, Carrie, please tell your friend she can get reevaluated, and if they find that there are deficits that remain, they can work on them moving forward now. And I'm picky, I would want any rehabilitation specialist that my friend or family member works with to know this stuff. So I would encourage her to ask some questions about, what's your view on recovery of whatever it is. I'm going to just say hand function, even though my stroke was 5 years ago. What do you think about that? How would you approach it? Things like that. Diane, you said the doctors at Gaylord Hospital should be forced to go back to school to relearn the basics. I understand that sentiment. And that's a rehab hospital, isn't it? I think it's one of the highest rated rehab hospitals I've heard of. Ooh, that's not good. Michael being a vegetable, I just can't even imagine that. I'm so glad that you pushed and advocated for him, and I know it took a lot of time and energy and effort from you and him both, but wow, that was worth it because he's doing so well. So well. You must be so proud of him, and he must be so proud of you. You're the greatest wife, right? Remember that, Michael. She gets all the greatest wife awards. Tom, you said the brain is an amazing machine, though it's not really a machine, right? And you're an engineer, so you'd know. It's an amazing organ that possesses incredible skills, often tacit, that many clinicians, including doctors, are unaware of. There are some people who choose not to learn, but that takes another set of choices to make for both the patient and the clinician together. Okay, so let's go through that. So yeah, the amazing organ of the brain, it has so many incredible capacities, and things we're still discovering all the time. I remember growing up, I had people around me, I don't remember exactly who it was, maybe older family members who liked to drink wine, beer, and I had been through my health class in junior high school, and I was like, you know how many brain cells you're killing? You can't get your brain cells back if you drink them away with your alcohol. I definitely remember being like that. Miss Smarty Pants, right? So, yeah, you do. Some brain cells die, but we make new ones. Who knew? Recently, that was announced, just within the past few years, especially in the hippocampus. The hippocampus is the part of the brain that helps us to create memories and store them so that we remember our stories about ourselves. So it makes sense that the hippocampus would birth new memories because we need to remember new things all the time, right? And we need to create new memories. So we need more and more neurons for that. So there are little baby neurons. There might be more. Like, we know about the ones in the hippocampus, but yeah. And then, as Tom was saying, it has other incredible skills. So if you lose neurons, they rewire. Neurons are cells that are basically shaped sort of like this, right? And this would be the body of the cell body. These would be projections called dendrites that would receive information from the previous neuron that's nearby. And then at the other end, there'd be, let's see if I can get it in there. Okay, there'd be axons, which connect to the next neuron. So in connections like that, they communicate information. And so if the neurons that they used to connect to are gone, they grow new axons and new dendrites so that they can connect with other cells. So the brain wants to reconnect. We do have some things, that we want to try to encourage, and this is really new research, especially in aphasia and language rehabilitation. There's certain times when we want to encourage neurons to take up the functions on the same side of the brain as they were originally lost, and other times where we want the other hemisphere to also help. So, but that's a very complicated story. So then, Tom, when you're saying there's some people who choose to not learn, but that takes another set of choices to make for both the patient and the clinician together, I'm not 100% sure what you mean. So if you feel like expanding or clarifying on that, I would love it. But in the meantime, I have had patients who have said to me that they're okay where they're at, right? It could be a very high functioning patient that's almost back to the way things were before the stroke. It could be a lower functioning patient where I might be surprised, but it's not really up to me at that point, right? So if someone says to me, I don't want to work on this anymore, for the things I do in my life, this set of language skills is fine. I won't necessarily relate to that because I'm a talker. I just really feel like I would want to keep working on my language skills, but that's my viewpoint, right? So sometimes a clinician has to consult with their patient on what's their viewpoint. Actually, we don't have to do that sometimes. We have to do that always. I believe in patient-centered therapy. So I might be surprised if a patient says they don't want to work on that anymore. But I've heard different reasons through the years about why people made decisions like that, and some of them I can understand. So some people feel like they can only concentrate on relearning one thing at a time. So given the choice between learning to talk again or learning to walk again, for some people, walking is their priority. Any one of you who knows me knows that's not my choice. Talking would be my priority. Yeah, I'll go in a wheelchair and I will talk. That would be my choice if I had to only pick one. But other people are different than me and they want to walk. And remember what I said before, you can come back and work at language another time. Just because you stop working on it for an amount of time doesn't mean that you can never work on it again and that it can't get better. We can improve anytime you go back to working on it. Okay. Let's see. Comments. So Diane is thanking someone for a compliment, I guess, saying that Michael is walking, talking, driving, totally functioning today. He continues speech therapy 3 times a week and is flourishing, and we will never stop. And we have some congrats to you, Diane, and to you, Michael. So, yeah, driving. Okay, so that's an interesting one. A lot of doctors forget to bring this up to people who had strokes, that maybe they should not drive right away. There's several reasons for this. Some people have seizures for a while after a stroke, and if you have a seizure while you're driving, you could cause an accident. Some people have visual impairments that came along with their location of their stroke or brain injury. Some people have some cognitive disorders. That's not aphasia, but you can have that and aphasia. And some people don't have the right coordination for their musculature to work. So for a lot of those things, there's workarounds. I remember, Diane, you remember in our group that we had that one man who got, I forgot what you call it, but like it's like a knob that goes on your steering wheel so you can rotate it a lot with just one hand. And he got a conversion system for his pedals so that he could use his good leg to drive, which was the left one, because his right one couldn't operate the pedals like would normally be. And the cool thing about that equipment, I had never seen that before, was it was removable. So if his wife wanted to use the car, she could use the pedals in a normal way or typical way. So I love that Michael's driving and that those other people are getting back to driving. There are some people who, for different reasons, as I said, should not be driving and need to think about that before they go back to driving. There are even evaluators for determining whether people after strokes, this is not just an aphasia thing, I'm talking about stroke and brain injury in general. So there are people, there are some driving schools that can do that, and there are a lot of occupational therapy programs that can do that. And they usually have really cool equipment. So it's almost like those airplane simulators you've seen pilots train in, or like a ride you might have done. But it simulates all the different things you'd have to think about at the same time and switch attention and multitask while driving. So it gives you the visual of the road, and it has the mirrors and the side mirrors and the controls for the air conditioning and everything. And they give you situations and scenarios, and then they can tell you if they think you're ready to drive. So that's another way to have somebody checked for safety on that. So Tom, okay, let's see. Using photosynthesis, okay, so converting light into green leaves is a metaphor for plasticity. Okay, so let's think about that. So converting light energy into green leaves. Plasticity in the brain, converting thoughts and activities into neural matter. That uses the remaining cells to grow new branches and leaves and synapses and create the needed connectivity, allowing language to flow again. That's a great metaphor. Tom, you always come up with such interesting thoughts and philosophies about things. I mean, some of you may not have heard of Tom Broussard, but he's an incredible man, an incredible speaker, an incredible example of what you can do to help yourself with aphasia. And he has really useful books called the Stroke Diary series that I highly recommend. I think they're amazing. And he goes around and speaks at different schools so that speech pathology students will see the latest research in action by someone who experienced it. And he has an incredible backstory. You know, he had a wonderful military career. He met amazing politicians. He was an engineer. As a older adult, he went back and got a PhD and worked in a university or a college to help people with disabilities find jobs, just like an amazing history. And then he had a stroke, like soon after the PhD was completed. And he just, from his engineer and different kind of view of the way things work, he kept these stroke diaries, literally, where he outlined what he was experiencing inside his mind, which is always interesting from an outsider's point of view, right? I can't know what the person thinks in their head. Like, do they think they're saying the words that I'm not hearing out loud? So he talks through his books, and he uses these visual pictures that he would make. So this photosynthesis analogy is another good one, Tom. But I love the construct you have that you're a stroke educator, right? You're not a stroke victim. You're not a stroke survivor, even though that's such a positive word. You're a stroke educator. You go around and you educate. You literally do that in your books. You do that when you go to schools and teach the future speech pathologists. You do that when you go to aphasia groups and educate other people with aphasia about what can be accomplished. And you do it in your everyday life by being an example of what you've accomplished. So I love that. Thank you, Tom, for all of that. Okay, so Debbie, what if the person is quiet by nature? Should you make them talk? That's interesting. So let's think about this. I don't know, Debbie, if you are someone with aphasia or are a speech pathologist or someone you care about has aphasia, but I'm going to say you have to find out what they were like before the neurological incident. So I believe, like I said, in patient-centered care. So one of those things is really exploring who that person is and who that person was, even though they're still right there because of changes. Sometimes they feel like they've changed as a person, right? So you need to figure out their values, their ways of thinking about what's important to them and what they want to accomplish in therapy. So would I say you would force people to speak just because you're a speech pathologist? No, I wouldn't say that. I would say, I think I talked about this a little earlier. I have a hard time sometimes from a personal point of view understanding people who aren't talkative because I'm talkative. And I hang out with a lot of talkative people. But yeah, there's a lot of people who are more introverted, quiet by nature, as you said, just communicate in shorter sentences, only communicate when they think it's really important or they really are adding something new to a conversation. So there's a lot of reasons why people might not be talking so much, right? So no, I don't think you should make people talk, but I do think they should be encouraged to try and improve if the language is a barrier to things they want to accomplish. So if they want to resume an occupation or the person wants to talk to a friend, then yeah, I think we should encourage the person to speak more. But no, I don't want to push someone past their natural inclinations. I hope that answers your question. If there's more to it, please put it back in the comments, okay? I love this one, Maureen. How much is enough therapy? This is my view on that. There's a few things here. Okay, so I'm not sure which one you're asking, actually, because you could be asking me how much therapy should someone receive each week, or how long should someone receive therapy, or when should someone stop therapy. So let me go through each of those, okay? How much is enough therapy? We estimate, based on the research that I've read most recently, that people do best with 4 to 9 hours of therapy a week, but that can be for short periods of time with then breaks in between. Some people go very intensively, like 6 hours a day, 4 hours a day, 5 days a week for 2 to 6 weeks. There's intensive programs out there like that. They can be very costly, but they can also really be a good kickstart for someone, or get them over, let's call it a perceived plateau, because I don't think there's really a plateau. I think there's times where the brain is integrating knowledge, and during that time on the outside you're not seeing more progress, but inside there's still things happening. And when people get let go from therapy due to plateaus, they're really being done a disservice, because they could be just around the corner from another major progress. So I think a recovery curve is more like plateau and then up, and then plateau and then up, right? I don't think it's like a straight up. So if during one of those leveling off periods when maybe the brain is integrating and doing cellular things, they might think that they're not recovering, because on the outside they're not saying more, but they might still be recovering quite a lot. It's kind of like, let's use an analogy like Tom was saying, or a metaphor. Like when they say check out, and when you're doing weight loss, for example, don't always go by the pounds. Sometimes go by the inches. Do your jeans fit looser? Things like that, right? So the scale doesn't say that I lost weight, but I gained more muscle perhaps because I'm exercising more, and that would made me like tighter and smaller a little bit so that my clothing fits looser. So there's a different kind of progress still happening, but if you only go by an outward measurement, it's not going to show up. And so that's why I don't like the idea of a plateau being a point to stop someone from therapy. And that is used in many insurance and third-party payer plans as an indicator that someone should stop therapy. And I just don't agree with that for a lot of reasons. And again, how much therapy is enough? So in terms of like, when would someone stop therapy? I attend a lot of continuing education conferences and events and courses, and there's one, I call her the grande dame of aphasiologists, Audrey Holland. Dr. Audrey Holland is so well known in the field. I think everyone respects her, and she has just done so much for, patient rights and positive psychology and just all kinds of things. She's created standardized tests, all this. So I attended an event where she was speaking, and she was like my academic crush. I think she's everyone's academic crush, actually. But I had a picture of me and her up as my profile picture for a while. But I was like, I'll just put me. Anyway, so Audrey was speaking about many different topics, and it was an audience of speech pathologists. And someone asked this exact question, like, when do you stop therapy? Like, when is it enough? And she said, which I thought was brilliant, she said, the person doesn't need therapy when their life becomes therapeutic. Breaking that down, that's like what Tom said, right? If you're constantly out there learning, challenging yourself, doing activities, pushing forward so that in your own life you're making progress every day and not limiting your choices of activities and things to do, then your life has become therapeutic. You're learning from your environment, you're engaging with people, with ideas, with thoughts, and you are doing well. Your life is moving on. That's when you don't need a professional speech pathologist anymore. Okay? Some people have trouble getting to that point, right? They're not initiators. They need someone holding them accountable, or they thrive with person-to-person interaction. Other people can go out and create their own activities that enhance their communication, their comprehension, their reading, and their writing, because those are the four things that can be affected by aphasia: reading, writing, speaking out loud, and auditory comprehension. So if a person is doing all those things and happy living their life the way things are, they don't need speech therapy anymore. I hope that answered your question, Maureen. Please continue asking if there's further questions. Debbie, so one-handed devices. Yes. Okay, so I am not an occupational therapist or a physical therapist. So devices and compensatory materials to accomplish things one-handed is not my area of specialty, but I know there's great blogs. I think Trish Hambridge has one about living a one-handed life. So does Paul Berger. I think that's his name. And there are devices out there that will stabilize things. So let's say you have to do some cutting. There might be devices that have suction cups and then like a sharp thing, and then you can put the vegetable or whatever you have to cut onto the sharp thing, or you can use a mandolin. So there are a lot of different devices. There's also things that, like, there's something called Dyson. It's like a sticky plastic that you can just put down underneath something. So let's say you could put it down like a placemat under your plate. That way your plate's not moving every time you use your fork against it. But definitely search for one-handed or stroke gadgets, things like that. If anybody knows of a good source, please type it in the comments so we can share it with Debbie. But that's a good question. And one of the things, I told you this is not really my area, but that's why I was so amazed with the things they were able to do for Bob. Thank you for reminding me, Diane. So that he could steer his steering wheel with one hand, right? And other people have told me about one-handed scissors, and someone was talking on one of the Facebook groups yesterday about not being able to follow the instructions for making homemade fabric masks for the COVID-19 precautions. And there was a video on YouTube I posted on there in an answer of one someone did with a sock and 3 cuts. My mom, who's probably on here, she told me about that, so you can check that out. I think that's on the Talk Aphasia page. Charles, driving. Major rehab hospitals offer the driving tests, right? Those are occupational therapy facilities that are incredible. And yeah, they can do them live like you would with a driving instructor, or in those simulators. Did Barbara do one of those? Is she driving? Diane, remember? He was so excited when he was able to regain his independence, because I'm sitting here calling it driving and you're saying what it really is. He could get out of the house and go do what he wanted and have independence and feel like a functional adult again. Incredible. I know someone who I'm working with now whose parent is on here, was also very excited to get back to driving. So yeah, that's independence. That's a big step. Tom, I I feel like I'm underselling you. You're very welcome. Okay, let's hear what Tom thinks about Maureen's question. How much is enough therapy? Okay. He says a different approach to the same question is how much therapy is needed to induce the habit-related activities to become as automatic as habits often do. Deep thoughts. So good. Right. So instead of thinking of how much therapy, it's how much does the person need to kind of push themselves outside of their comfort zone to rebuild new habits that will ultimately continue them on their journey of improved speech language communication. Totally true. Because a lot of the habits you had prior didn't involve anything to do with enhancing communication, right? Like before a stroke, most people weren't practicing constructing sentences or thinking about rhyming words or whatever technique you're using to enhance your communication skills, right? So you need to build new habits. Just like my analogy back to the gym, I haven't built these habits, but how much effort would I have to put in to building habits that would support me working out and keeping a healthier diet, right? It's the same question, but about a different topic. When you think of it in a different way like that, it is sometimes more obvious what the answer would be, because then you would see the autonomy, the self-efficacy that has to go into that happening, right? So someone has to say, like, this aphasia problem is something I'm going to handle, right? Like I would have to say about weight loss situation, I'm gonna have to say, all right, I've got to let go some bad habits, some lazy habits, some sitting on the couch too long habits, right? And I have to start doing more activities. Can't go through the drive-through all the time, have to cook, increase the vegetables, right? So what does a person have to do for themselves so that they have enough enrichment? Instead of therapy, we'll call it enrichment. So those enhancing activities that stimulate speech and language and comprehension. Very good. So Charles, you concentrate on talking, but what we really want is to communicate. When talking is difficult, what other ways can we use to communicate? Oh, I love this one. Okay. So as I said, I always want people talking too. But first, I want the communication, because ultimately there's something underlying what we're actually saying. That's some kind of brainwave pattern, right? That communicates from an area that has language and communicates it down to our musculature to say, right? But even before that, there's other parts of our brain that have the concepts. So at that conceptual level, there's a lot of work you can do. So, and it can be literally anything that works. So here, if you want to take notes, Charles, please write down supported conversation techniques. That's supported conversation techniques. Okay. One of the places where this originated, they also originated a theory called LPAA, but I'm not going to go into that right this second. But the idea with the supported conversation techniques out of this lab in Toronto, I think it is, Aura Kagan, A-U-R-A, Aura Kagan, K-A-G-A-N, is someone who's written about this a lot, and you can find it on regular Google searches. So you can find supported conversation, and you can find the lab in Toronto where they have great caregiver resources. There's videos, there's pamphlets, there's short ebooks that some of them are free and some of them you can purchase for a very inexpensive price that list out all these techniques, but I'll give you some ideas. So, and also if you happen to live near New Jersey, the Adler Aphasia Center uses a lot of this in their approaches, and they have a great website. And when we're allowed to be near people again, it's a great place for people to go. So, what to do besides talking? Okay, so one thing you can do, and these are all going to be things that you can either do or you can encourage her to do, right? So one thing you can do is when you're having a conversation, you can have supportive materials available to her. So you can have, let's say, charts, pictures of people, common places, you know, the post office, the hospital. You can have people, when I mean like that, you could have doctor or like a friend. You could even have a real picture, things like that. So if she's going, a lot of times people with aphasia will say very non-specific things like, the one, that one. And you're like, are you talking about a person? And you can show her then the person words or the person ideas, and she could help you clue in. And that's not using it as a compensation. This is using it as an enhancement, right? So then you say, oh, you want to know when the doctor appointment is? And she might say yes, or it might be something else about the doctor, but then you'll have to figure that part out. But so you can have pictures, you can have maps, you can have, I like these wordless dictionaries. They have like every concept, and they're great for people, like, for example, who are learning English as a second or other language. So they might have like a whole page of vegetables and just showing. And then you can have her say the word, right? So I want broccoli. And then she can do broccoli with you, even if she has to model it. But maybe after she hears it once, she can repeat you. And then maybe you can talk about chicken and broccoli or something related to that, right? So you can build off of things. So you can have pictures, you can have, like I said, maps, visual dictionaries, calendars, if you need to talk about time, all different resources like that. And then you can have a clock, a picture of a clock to talk about times as well as calendars. And then yes and no. Usually yes, like a big yes in green and a big no in red. But a caution there, yes and no can often be mixed up because basically they mean the same thing, except one's an affirmative and one's a negative. So sometimes giving a choice of two things is better than a yes or no. Like, are you talking about the doctor, or are you talking about the priest? I don't know. I don't know. I can't think of anything right now. But for example, like you can ask a paired choice, that would be called. Or if like, what do you want for breakfast? Do you want waffles or do you want eggs? And then if she says something, you say, do you want waffles? And she's probably going to nod, and then you can then say the talking part as well. So all I'm saying is, like, you can add the talking at the end, but I agree with you completely that the really important part is the communication, right? And a lot of speech pathologists are looking for a right answer. That's one of my personal irks. I don't like that. I think if I get the message, they got the check mark. That's how I feel. And then I'll still try to get the word, right? So what else can you do? You can write down some keywords. If you're talking about something and you're not sure she's following, you can say, let's say you want to say, what movie do you want to watch tonight? You can write down movie or TV and then say, what movie? Do you want to watch a movie? You know? So some people are helped with other modalities like reading and writing. So if she can write a keyword for you. A lot of people who can write better than they can speak, they don't want to write because they want to speak. But if you frame it in the right way as just a tool to get the message out, and then you can help with the word coming out, then that sometimes will help somebody be more willing to use their writing modality. So, and drawing a picture would be another thing they could use. So anything, pantomiming, gesturing, going and getting it. I've had people say, like, they're trying to tell me something and then they get frustrated and they're like, ugh, and then they just go get it and it's like a spatula or something that like I wasn't going to think of. So anything at all that can help the message get across or the message be understood depending on the difficulty, use that. And then just add on to it by having, the word said, or you can give like a leading sentence. Like, let's say you wanted to talk about that spatula. Maybe you want to say something like, you flip pancakes with a spatula, right? So you leave that like pause there for spatula, but you've given a leading phrase with a semantic, like meaningful piece, like you flip the pancakes. That's going to make a lot of people think of the spatula. And then you can even give the first sound, so that helps them as well. So if I say to most people with aphasia, you flip pancakes with a they're pretty much going to say spatula. Like it happens a lot that they're able to do that. And then they build some success and they feel really good about it, and it just builds more confidence, and then from there you can build like more trust and rapport with the person, and they'll start to trust you with more challenging activities. Charles, tell me if you need more. Okay, Debbie. I just made that comment because I am an OT. Oh, right, we talked the other day. Okay. I happen to have a young adult born with aphasia, which you call developmental language. I spoke to you on the phone, right, a few days ago. Yeah, so let me go back. What was your original question? It was about one-handed devices. Yeah, so that can be really important for someone who's had any kind of brain injury that affected one side. But there are really good options, and OTs are a great person to consult. OTs, occupational therapists. And yeah, there's really cool YouTube videos, websites, blogs about living with like a one-handed lifestyle, that kind of thing. Maybe there's even amputee websites. But there's definitely stuff out there. I just don't know as much about it as I know about speech language cognition stuff. Let's see. So Tom, are you telling me changing the description of what therapy does? Is that in reaction to what we were talking about earlier about like the speech pathologist driving the therapy, right? So instead of the person being reliant on the speech therapist for activities, they should be thinking of therapy as strategies to build the habits that would support their own continuation of language improvement. Am I getting that right? Because I think that is a really interesting new definition of what a therapist could do. I think some people need, very specific interventions and benefit from a lot of direction and accountability, but I think there's a lot of people like you, and there's other people I've met that are very self-driven, and they would probably respond better to a therapist approach like that, where they're like, this is what you can do to support yourself. But so I teach a lot of master's students who are becoming speech pathologists, and that's not a topic in any course that I've heard of. So that's a really interesting idea. That's not one of our options that we're currently thought to talk about and think about. So I like that one, as usual. Okay, Carol, do you think a person's pre-injury personality, for example, easily stressed or depressed or frustrated, can be the reason they stop speech therapy too soon? And if so, how can they be helped? Yeah. So yes, I do think that can be one of the reasons that people stop any kind of therapy early. And as we were talking about with other pre-existing personality traits, like the more quiet person, right? We do have to keep that in mind because our outcomes and our goals are all going to be different for different people because of all of their own personality characteristics. The interesting thing about easily stressed or depressed, right? So those are sometimes thought of as brain-mediated disorders anyway, right? So a lot of medicines that are used currently for treatment of stress and anxiety work on the neurotransmitters between the neurons in the brain. And so actually stress and depression can be something that is affected by a brain injury. It can be exacerbated, or even for someone who didn't have it beforehand, it can be an organic cause of a new depression or anxiety because something about the brain was disrupted in a way that those circuits were affected. So we often have to refer people to psychiatrists or therapists that do a very behavioral approach to change behaviors, or even like a neuropsychiatrist who specializes in neurological psychiatric disorders. So that's even more specialized. So sometimes medication can help people build their motivation back again, and then we can take them back on speech therapy if they had quit, or if they're thinking of quitting because of these things. We often recommend that they see a doctor to see if something medically intervening, like a medication, I should say, would help. And another thing is really to show people the progress they're making. Some people get depressed because they don't think they're going to improve, or they think they've heard these stories that you're not going to improve after a certain time. So sometimes that can be very encouraging as well. And sometimes someone like a stroke educator coming in and really talking to someone about their experiences, and look, it took me 2 years, but look where I am now. Maybe they need, motivation as well. So there's a lot to that question, so I hope I answered primarily what you were asking, but I definitely think that does cause some issues in therapy and compliance in therapy and motivation in therapy. Oh, the Adler Center, and you met Dr. Holland there. All right. So we know a lot of the same people, right? So Charles, it's so funny. I want to tell you, Dr. Holland, Audrey Holland, that I was telling you guys about before, who I said was my academic crush and the grande dame of aphasiology. There's one group called Aphasia Access, and they give out awards for speech pathologists. The one who, did the most in their community, or there's the awards, and they're called the Audreys for Audrey Holland. Nobody in our field wants an Oscar or an Emmy, they want an Audrey. So I love that. So Charles, yes, aphasia can be complicated by many other accompanying disorders. You mentioned dysarthria here, and let me just clarify what that is for people who may not be familiar with the terminology. So dysarthria is a motor speech disorder, and what that means is the person's language, let's just say pure dysarthria, because if you have aphasia and dysarthria, this is not true. But if you just have dysarthria, the language part's okay, but something about the muscles or the way the nerves are innervating the muscles make it so that the muscles are weak, or hypertonic or hyperfunctional or hypotonic or hypofunctional. So people might have slurred speech, maybe difficult to understand, maybe losing saliva out of the mouth, things like that, where there's something wrong with the motor use of the face or articulators or whatever part is affected by the dysarthria. So if you have that and a language disability like aphasia, yes, it makes it even more complicated, which is why using those strategies we talked about could be even better, because it could take some of the stress off of her musculature that needs to say the concept she's already struggling to say with the aphasia. So one other thing to say about dysarthria, and this is another new thing that not every speech pathologist knows, okay? We were taught, like back in the 90s, like Nahama said earlier, to do oral motor exercises for dysarthria. So that would be things like mouth exercises like ooh, ee, like not even with the ooh, ee, just like purse your lips, smile big. Stick out your tongue. I can't talk and do it. So stick out your tongue and move it side to side. Up and down. Nose to chin. Things like that, right? So kind of like working out for your face. We were taught that's what you're supposed to do for dysarthria. Well, okay, so it turns out that's not the best way to help with dysarthria. So the best way to help with dysarthria is to do what I did automatically, because I know that that's the best way. And you have to make it linguistic, right? So if you're doing the pursing lips and the smiling, you do ooh, ee, movie, something like that. So like you make it sounds, speech sounds, syllables, something to do with speech, so that you're reprogramming the connections between language and sounds and muscle movements. So if anyone's giving you like look in the mirror and do these exercises 10 times, that's old. It's not the best way. It has to be tied to linguistic speech movements. Okay. Replying to Carol, Tom says, Carol, good question and observation. I think that, so this is in response to the question about someone's pre-existing depression or anxiety and quitting therapy too soon. So Tom says, it's a good question, an observation. I think that can be often the case, and unfortunately with clinicians who don't yet know the pre-injury understanding of the person sitting in front of them, and the therapy stopping for some of those tacit understanding, with neither one knowing what the other was thinking, hence doing, can be the next step by stopping before therapy is still needed. Right, so I think to summarize that, we have to talk to our patients, clients, people with aphasia in our care as speech pathologists. We need to dig a little deeper as to what's causing somebody to want to stop, but also it serves to know them up front, right, Tom? So like, I want to know, were you a talkative person before, right? Because that was a really good point that was made. Like, what if the person wasn't a talkative person? Like, that makes a difference in whether I feel like, we're all accomplishing the goals that that person needs. So, yes, I think there's a lot of clinicians who are still practicing who don't do that, but I think we're building clinicians who are doing that. And a lot of the things that I go to that I've seen you at, we're in that trench together trying to build the clinician, patient, and care partner and researcher, right? Interplay much better. Having those conversations is super important, and I'm hoping we're getting in that direction, because there's usually a motivation for why someone's quitting, and it could be a pre-existing condition like Carol said, or it could be something else, or it could be a new organic problem, or they could just be in a downward part. Like I said, I don't think any path is straight up. it could either go up and down with little glitches, or there could be those plateaus. So we have to see if they think they're not improving. Maybe they just need to know that they will continue to improve in another couple of sessions, you know? So, good points. Okay, good. So I did understand your question. The habit of making habits for SLPs, speech language pathologists, to become like teachers of how to make better habits so that the person has more autonomy. I love that idea, and that's new to me. Charles, speech therapist Helen Hayes used an iPad to record and play back to Barbara how her speech sounds. That was a major revelation to Barbara and motivated her to work on her dysarthria. So that's interesting because it sounds like she wasn't aware of how she sounded. So that can happen, especially if brain damage occurs in the left temporal lobe, and she doesn't have a good sense of her auditory feedback. So that may be part of what happened in Barbara's case. So that's really interesting. Maybe when she heard it from an outside source, she wasn't processing it as her own, and she heard it differently. That might not work for everyone, though, to even for them to realize it. So I'm glad that worked for her. But there are a lot of brain injuries where the person has a very decreased awareness of their limitations. So that's something to keep in mind. But that's not aphasia, again. That's something that can come along with it, right? So Tom says, "Hi, Charles. Thanks. That's so good, and so glad that someone is using recording as a useful tool in aphasia recovery. My 5th book, called Stroke Diary Voice Memo, another tool in aphasia recovery, to be published later this year." Okay, so you're going to have a whole book on that. Good for you, Tom. I love the Stroke Diary series. I mentioned it before to everyone, but this is the series I was talking about. I obviously have not seen this 5th book, but I am up to book 3, and they're good. Okay, Lynn, you said, my son has a brain injury, and after about 4 years, finally was told he had aphasia, apraxia, dysarthria, and now I was working with a private speech therapist, and he said he doesn't have apraxia, but he has one of the most severe cases of spastic dysphonia with larynx and voice issues he's ever seen, and his voice box needs to be programmed. It's so confusing on what he really has and what to do. That's interesting, because I'm going to show this for a minute too. I'm going really low tech today, but I had this pre-planned because a lot of people commented on my post of this, which is a flow sheet of how we type what kind of aphasia a person has, because there are several types and they have different characteristics and different likely speech patterns and treatments. But there's also all these different motor disorders as well, which you just mentioned a whole bunch of, right? So we talked about dysarthria briefly, with that being like the deficit of a muscle or the innervation of a muscle. Apraxia is different than that because it's a planning problem, not a muscular problem. So sometimes the plans get through and sometimes they don't. So in that one, you'll have someone with an inconsistent presentation of speech, whereas dysarthria, the muscles just don't work. So no matter what they do and when they're doing it, it just won't work. Let me differentiate the other ones for you. Aphasia, which is a language disorder. Okay, and then dysphonia. So dysphonia has to do with the laryngeal level of speech control and with the vocal fold vibrations. So that's usually termed a voice disorder and not a motor speech disorder. But is there really a separation, right? We have to do it to categorize certain things for teaching students about different types of disorders, and we have to do it for billing purposes, and we have to do it because some of these disorders are more likely to be seen with other disorders than than others, right? So it's more likely to see somebody with spastic dysphonia have laryngospasms or vocal fold pathology like nodules or polyps or incomplete vocal fold closure, things like that. And so we classify spastic dysphonia as a voice disorder. But at a neurological level, it's still a disorder of motor speech. And so, even though somebody else might call it a dysarthria, right? Because maybe the larynx is hypo or hyperfunctional, it really still is a dysarthria in a general sense, but we classify it differently. But it's still an innervation problem to the muscular control of the larynx. So you can hear basically synonyms that sound like different diagnoses. Does that make any sense? Let me know. Thank you, Carol, for my happy birthday wishes. I'm so glad you're here. Good to see you. Okay, Diane, you said have clinician take the patient for a walk. Talk about the day, the weather, whatever, to encourage patients to talk and share feelings and emotions going on inside their brain. Use smells to bring about sensory elements. Diane, like I said about Tom, I want to say a couple of words about you. So not only is Diane here as a care partner to her husband, Michael, who she mentioned was told would be a vegetable, was in a coma, would never walk, talk, nothing. And I told you, I've met this man. He walks, talks, drives, and is hilarious. And demanding of his speech therapist. And I love him. But she is not only his wife and care partner, but she is also a counselor for bereavement and transition and change. And so she's come to my classes to talk to people about loss and change, and ambiguous loss, about the fact that you lost a person but you didn't lose a person because the person's still right there, but they're different right now. There's a lot, a lot of complex emotions, and she's so good at this. And so not only does this have an element of that, caretaker, therapeutic, brain, comfort kind of thing, this is also so true about stimulating a person to speak or communicate in general, right? So she says, take the patient out for a walk. Okay, so walking. We're getting them out in the fresh air, using their legs, bilateral use of their body. That is very stimulating for the brain. Talk about the day. Okay, so talking about something as innocuous as the day and the weather, whatever she says, to encourage the patient. That is such a normal thing we do, right? Small talk, talking about the weather, how things are going. Oh, look at the flowers. Oh, that is something we're so used to doing that it's a way to like really reach a person and almost distract them from their current circumstances because it's so normal. And then she says, encourage them to talk about and share their feelings and emotions going on in their brain. So like, a lot of our therapy that we're taught to do with people is about checking off boxes. Did they say this? Did they understand this? Did they get the yes? Did they get the no? But there's a whole person there, and they've experienced a trauma. And, giving them an outlet to talk to someone is just so valuable. And I remember, I think I told you guys about the adult day health center place I worked at. We had team meetings every week about our patients, and everyone had their viewpoint about, what was going on. We had the dietitian, the doctor, the nurse, the social worker, everybody, OT and PT, sorry guys. And I would listen sometimes, and the social worker would tell me, and this person, is being planned for discharge on this day. And I'm like, well, what about all the stuff he's going through at home? Or what about, and they had no idea. That person talked to me about, the struggles at home, not being able to answer the phone, not being able to talk to their child's teacher, not being able to find the groceries in the store. The social worker had no idea. Like, when she met with them, she was there to check the boxes off she needed to do for, her work of like discharge and maybe filling out forms. But they talked to me. So, yeah, super important, Diane. Thank you for all this. And use smells to bring about sensory elements. Yeah, you guys have probably heard about this. If not, they even use that to help people stimulate them while they're in comas. Lynn, I remember speaking to you a while back. Thank you for being here. Oh, Tom, yes, because I said I'm at the third book, right? You said the fourth is the ABCs of aphasia. Oh, coming out next week. It's not a stroke diary one. Okay. Something new for everyone. Okay, great. So I think I've come to the end of the current questions, but keep them coming. I hope this has been useful and interesting. We started by talking about some of the old-fashioned beliefs that are still tossed around, right? About these myths of plateaus and the myths of the 6-month to 1 year recovery course, and then that's it. And that's not true. But I wanted to also bring in a couple of other things because our time is kind of running down. I guess I could talk forever. I want to talk about the care partners out there, right? So Diane, Charles, Carol, all of you, and I'm sure there's others that I'm forgetting, Lynn, you're taking care of or assisting or helping someone you care about with aphasia, but you're also living your life that's drastically changed, right? So what do you need, right? Do we talk about that enough? I'm not sure speech pathologists get enough training about that. So, I feel like our curriculum for master's speech pathology students should be more inclusive of giving people resources, whether it be through us or through recommending and sending them to a different type of expert. I think care partners need a lot more support. Hi, Richard. Nice to see you. Thanks for being here. So the care partner stuff, I definitely really want to focus on that in this group a lot going forward. Today, kind of answering anything and everything, but in the future, one of the things I want to attend to is, reminding care partners to prioritize their own self-care. We all know the metaphor of a plane, when the oxygen masks come down, you have to put them on yourself before you can put the one on your child, right? So you have to take care of yourself and have your own personal integrity and self care in order to take care of someone else. And care partners are under tremendous strain, right? They might have just lost their primary income. They might now have to arrange a whole lot of foreign sounding doctors and processes and papers and things like that. So this is a big, big issue. And I would like to talk more in the future about encouraging neuroplasticity and ways to motivate people to work on their own, like Tom suggested would be a really good new angle for a speech pathologist, right? To help the person to build new habits rather than focus on individual exercises. So, Charles, you said a key element of long-term rehabilitation is attending a stroke support group. It's educational and it's social. Haha. Well, some of you who are on here met me through one that I had started. I totally agree with you. I agree that people need support, they need tips, they need strategies, they need education. I don't know if you get a chance at these groups for you as caregivers to get education, but that was something I tried to pair when people with aphasia were meeting with therapists, student therapists, and supervisors. I tried to have programs for the caregivers. Wink, wink, Diane. Diane was always there for them. She's great. And I think everyone needs social stuff. If one thing has shown me that, it's this COVID-19 situation. I always think I want to stay home and be by myself and do nothing, and I miss human people. Anyone who knows me is probably like, what? She wants to go out of the house? She wants to talk to people? Like, I like to stay home and do my own thing. And no, I miss going to things now. I'm going to be a new party person after this is over. But everyone needs support, right? And even, I want to say another thing. Groups are great for people with aphasia because it's so good to see you're not the only one. It's also so good to see someone who has progressed beyond where you are, so it's possible for you. Plus, there's nothing like the camaraderie. I mean, people supporting each other, encouraging each other, saying, give it another try, or just take your time. Like, because they're there for you. Like, and making new friends. A lot of people with aphasia, it's heartbreaking. Like, their friends just disappear over time. They don't know how to interact with them in this new way. And that's an incredible loss of who you thought your support system was. So making new friends and people who get it and are in it with you is super important. I love group therapy. I love group supports. I actually have written papers on group therapy for people with aphasia, where I had mixed levels of people in my study, right? So I had some people who were very fluent and could say a lot, and some people who were at the one-word level. And so what I did, it's hard, and you have to have a lot of experience to manage it with just yourself. But I can manage that each person gets the cue they need that will still challenge them, but give them enough support, while giving another person a totally different set of circumstances and letting people converse. And I had really good results with that paper. Actually, if any of you want to look on Google Scholar, it's like semantic feature analysis, group treatment, something like that. You guys want me to start a new support, a new group? I would love to. I just don't know how to get that funded and started because right now I'm not associated full-time anywhere. So Charles, you were adding that aphasia is rarely a standalone problem. It's part of a stroke or TBI and something else. We caregivers deal with the whole person, not individual symptoms. Exactly. And that's what I think speech pathologists and all rehab professionals should be doing. I really do. Richard, you're asking if there's one support group for locally where you live for your daughter. There might be when schools start up again, because Adelphi and Hofstra, I think they both have stroke support groups. I think Malloy only had individual one-on-one student sessions. So check back with me when schools are starting up again, and I can find out the details for you. Or feel free to search online for Hofstra and Adelphi under their speech pathology department and see if they offer them. Okay? Hospitals sometimes have them too, but I know that either Adelphi or Hofstra or both of them have a stroke support group. I want to add Charles, the standalone issue, right? So here's where it gets sticky. When we talk about aphasia, we generally want to focus on the fact that aphasia in and of itself is just an impairment of language, okay? Because people with aphasia, I think they're already, it's a misunderstood situation. People think because you can't speak that you're not intelligent. So a lot of taglines have to do with aphasia being a disorder of language and not intelligence, okay? But you're right that a brain injury is very rarely so localized that it only affects one thing. So you may have other deficits that are not the aphasia, but were caused by the same thing that caused the aphasia, right? So just to be particular there. But and especially with TBI, right? Because then it's a diffuse brain injury. Maybe the brain got hit in a couple of places, right? Because let's say even in a driving accident, right? So if you're moving quickly, your brain keeps moving even if the car stops, and your brain smashes into the front of your skull. And then it bounces back and then hits the back of your skull. So now, and then if you twist it, like it's a very diffuse injury. Many things are damaged, right? So in TBI, that's very typical. In stroke, it can be much more localized. But even then, there can be accompanying symptoms, right? And I agree with you. Caregivers deal with the whole person, not just the symptoms, and also have to deal with their own lives and all the other things that they were dealing with before the person had the stroke or injury of whatever sort. So caregivers are under a lot of stress and pressure, and we need to recognize that as a group of treatment professionals, right? I also want to go back to the fact that I think we need to be patient-centered, meaning that I need to know who this person is, what they like, what motivates them, what style they respond to. And so in the beginning, I'm interviewing, I'm talking to family members, I'm feeling them out, I'm doing my best to decode all that so that I can design therapy that they'll want to do, will continue to do, and will push them at a challenge, but not at a failure rate that makes them want to give up. It's a lot of a balancing act. Start one again, Richard. Yes, I would love to. I just don't know where. But I think Adelphi or Hofstra will give you what you need when we are allowed to associate with others again. At Helen Hayes Hospital, we have a special breakout session for caregivers. Exactly. That sounds wonderful. And that's what I was trying at when I was teaching as a professor at Sacred Heart University. And then I moved to Long Island, and I don't work at Sacred Heart University anymore because that's in Connecticut. So that's a little far from Long Island, which is like southern New York. Tom, responding to Charles, I agree with both of your comments. Stroke support groups are as therapeutic as any other individual speech sessions, and as you said, rarely a standalone issue. I completely agree. Are there online support groups? Oh, yes, there are. Okay, so since we're getting down to the end, I'll tell you a couple of online support groups. So one on Facebook is Aphasia Recovery Connection. That's Aphasia Recovery Connection. They have a lot of people in the groups, so there's a lot of feedback. And right now, because of the isolation, they've even upped what they're doing in terms of trying to keep people from feeling so isolated. Aphasia is an isolating condition on its own because language is a lot of the ways we connect with other people. So, and a lot of people lose their friends, as we discussed. So this online group, Aphasia Recovery Connection, is a great resource. And actually, if you got value out of what we did today, I would love it if you would either go to my personal page or one of the posts down below this one on my Facebook group and make a donation to them, because that's what I'm doing as my birthday fundraiser. And that was my impetus for doing this today, is that I wanted to help in that mission of ending isolation, because with this COVID-19 situation, people are even more isolated than usual. So Aphasia Recovery Connection is really good. And I also really like Aphasia Toolbox. That is run by Bill Connors in Pennsylvania, but he does a lot of online things. He has discussion groups and therapy online, and a lot of people are offering therapy online right now. Everyone's moving to this distance model, so more might be available one-on-one in that way as well. Back to Aphasia Recovery Connection, I forgot to finish my thought, is that they are even upping their programs. They had lots of programs before, and they're a volunteer-run organization, so they need funding. But right now, they're doing groups every single day, and sometimes multiple groups per day. And if you're in the New York City area, there is the I Am groups, which are free groups run all over New York, at hospitals and universities. So you can look up the I Am, so it's I and then space AM, resources. And then there's a lot of resources listed in like the National Aphasia Association. They have partners and stuff, and so you can see groups all over the country in the National Aphasia Association. And then just search. You can search online for your local universities and hospitals and see if you can find one nearby. They're not online, but they're support groups nonetheless. Okay, so closing down today, I love this format. It was great. And I hope we'll be able to do another one of these again. But I also will be doing more targeted modules about particular topics, some in video form, some in post form. But I'd love to find out what you're interested in learning more about. So feel free on my group, in this group anywhere, to tell me about what your interests are. I might run a survey again. I put one in there and I didn't get any responses, but we're so new, right? We're just like 4 days old. So I want your ideas of what you'd like to learn more about, and whether there's any kind of ongoing course-like material you'd be interested in hearing about, or me developing. So I'm really excited about this new Facebook group. I think it's a way better way for me to really interact with people, rather than my professional page where it was like me typing and people couldn't post things. So here, people, you can all post to the page and make comments and start conversations. And I think that would be wonderful, because I'd really like this group to develop into a caring community of people where we share ideas, struggles, wins, and give each other support and strategies. And, you know, I went back for a lot of school, but the real reason I did that was to help. And so I would like to be a resource for you going forward. So thank you so much for being here and putting up with my tech issues in the beginning. And please donate to the Aphasia Recovery Connection if you can afford to. So thank you again, and I'm gonna go have a happy birthday dinner and cake, and hopefully I'll see you guys again on another live in the near future. Thank you all.